one name on that, by the way, about everything that you just read, which is my two names. That's the thing that brings a smile to my face for those, because they're just the joy of my life. It's so much fun. I'm really honored to be here today, and personally I'm honored, but I'm honored on behalf of Lancaster General Health. I don't know if you have had much experience as students with the healthcare system, either locally or in this general region. Lancaster General Health is the largest employer in Lancaster County. We've got about 7,500 employees. We're about a $1.3 billion company, and the hospitals are what people know us for, but we have lots of different companies. We have 19 different corporations that cover a lot of different healthcare services. And like everybody else in healthcare today, we're all trying to figure out how we're going to manage the turmoil that exists in the environment in which we're operating in. And that's what I'm going to be talking today about, is really this crossroads that healthcare finds itself in. And I personally find it really exciting because I love change, I love things to get mixed up, and I love being challenged to think about how we can really improve the health of the communities that we serve. And that's really exactly kind of the juxtaposition that we find ourselves in. So I would welcome questions, like if I'm talking about something that you have a question about, or if you have an insight you want to share. I don't need you to hold that to the end. Please feel free to just raise your hand, and if I'm not paying attention, then just call out Jan and I'll respond. But we're gonna talk about a couple things today. I really do hope this is relevant. I mean, I think that healthcare is a really important sector as you're looking at your career opportunities. Don't put healthcare on the side. Think about it. It has been a wonderful area for me to dedicate my career to, and there are tremendous opportunities from information technology to the full array of clinical services to all the business opportunities, which is more what I pursued. But it really is a dynamic sector and one worth thinking about. So there are really four primary things that I wanted to cover with you today. The first is really kind of setting the context for our conversation. Like, why do I say we're at the crossroads? So we're going to explore a little bit the macroeconomic trends that are really driving, in my opinion, the changes that healthcare is going through today. And then after we go through that, I'm going to talk a little bit and share some statistics about kind of where we are, what do things look like today, what's changing in healthcare. Things, and if I end up using some terms, I'm going to try not to, but if I end up using some terms that you've not heard before or you don't understand, please do stop me. I think it's really hard to get through a presentation or a conversation like this if somebody's using language that is foreign. So please do stop me if that happens. Then I'm going to talk about kind of the key themes of the change that we're going through as an industry. And last, I'm going to talk about provider response. And I'm going to talk about it from the orientation of Lancaster General Health, but I would challenge you to probably find other healthcare organizations like ours that aren't thinking similarly. So, I think the magic is never really in coming up with a response. The magic is always on your ability to execute on that strategy. So I'm happy to talk about our strategy with anybody at any time, because I think that, again, the industry overall is really challenged by many of the things that I'm going to be talking about. So let's talk a little bit about, again, these macroeconomic kinds of trends that are really influencing the transformation that healthcare is going through today. And you have to start by looking at kind of just healthcare spending and what's been happening with healthcare spending traditionally. And if you look at primary spending in the country and total spending in the country, and then you kind of, if you will, pull out healthcare spending, what you'll see is that healthcare really represents a disproportionate share of the expenses in the country today. And our revenues, as this shows, our revenues have been flat. Our revenues have been flat since 2010. So spending becomes really important as we try to get our arms around the deficit and our arms around spending in this country to try to get us in a better position in terms of sources and uses. So healthcare alone accounts as one of the largest drivers of healthcare expenditures. So getting control of that is obviously a key and important theme. So I love this quote by Alan Linder. He says, the implication for budgeteers is clear. If we can somehow solve the healthcare cost problem, we're also going to solve the long-run deficit problem. If we can't control healthcare costs, the long-run deficit problem isn't solvable. It's not going to be resolved. And there are many people who, when we get into conversations about healthcare spending and what's going on with the economy, always come back to this question around revenue. And they want to know, is there a revenue solution? And my perspective is that there are not. The federal taxes have historically run about 18.5% of the gross domestic product. And to solve basically our deficit, they would have to increase by 32%, up to 32% of the GDP. I think we would all agree that is simply not going to happen. So our bottom line is that the United States must have a less costly and a more efficient healthcare system. That it's not only important for purposes of being able to make healthcare accessible to everybody in this country, with and without means, but it's also critical to the long-term sustainability of our economy. So let's take another look at this. And this is looking at what's happened with national health expenditures and comparing that to the GDP per capita over the period 1961 through 2012. And I mean, what this really shows, if you look over the 51 years, is that healthcare was representing 5% of the GDP in 1960, and that grew to over 18.5% by 2010. So when you think about that type of disproportionate increase in healthcare spending, I think it helps you understand why we believe that that has to be arrested at some point. So the good news is that that's starting to abate. And we're starting to see some really very positive trends in terms of trying to get our arms around healthcare spending. Spending for healthcare increased by only less than 1%, 0.8% per person in 2012, which was just below the gross domestic product. And that was the first time in 50 years that that was the case. So that's a very positive indicator in and of itself. When you look at what's happening in terms of healthcare cost inflation, healthcare prices in October of 2013 rose 0.9% above October of 2012, and that is the lowest increase in 50 years for which we have data available. So again, inflation is slowing down, real spending is slowing down. And when we looked at it over the last 6 months, we saw that for 6 consecutive months in a row, healthcare prices grew more slowly than the overall economy. So healthcare expenses are falling below the overall inflationary rate. Again, a very positive sign. Medicare spending, which is always really important to look at when you're talking about healthcare, and I think that will be obvious to you guys, right? Older people use healthcare much more than younger people do. So looking at that 65 age group and above is really important to understand what's going on in terms of the healthcare sector. So when you look at Medicare spending per individual or per beneficiary, it grew at a rate of 1.7 annually from 2010 to 2012, which is dramatically below what that rate of increase had been for years and years and years before that, probably for more than 20 years before that. So we are clearly starting to have an impact on curbing healthcare expenditures. So now I think the logical next question is, well, why? What has changed in the last couple of years that would actually be enabling us to start to get our arms around these dramatic inflationary increases that have been happening with healthcare for so long? And I think there's a couple of really important reasons why that's happening. And keep in mind that this is happening at the same time that you've got this bolus of the boomers that are moving into Medicare, which is, one of the most important demographic factors that all of us are dealing with today. And you also have to keep in mind that healthcare spending isn't driven by hospitals. It's not driven by physicians. It's driven by a lot of factors. And in fact, what would you guys think that the most single important contributor is to overall healthcare spending in this country today? What would come to mind to you if somebody asked you that question? Take a guess. Yeah. Government? Well, Medicare and Medicaid, which is, I think what you probably are referring to in terms of government, is a huge spender. But I'm thinking, like, get below that and think, what are the things that are driving the cost of the government's programs?
Pharmaceutical costs or
Yeah, it's all about drugs. Follow what's happening with drugs, and you'll get a really good sense of what is influencing healthcare expenditures. And it's really kind of frightening. We have a very large geriatric program. We have 17 physicians that work just with, they're geriatricians, they work just with elderly folks. The average number of drugs that a Medicare beneficiary is on when they start coming to our geriatricians is 17. So when you think about all of the implications of being on that many medications, you know, one medication, you're on one medication because you're trying to address the symptoms of another medication. It's like this, you know, just kind of circular negative cycle that you're in, because you've got to get people off all those drugs to really evaluate what they need to be on, what's critical for them to be on, and what really just got layered on by every specialist that they went to see because care wasn't being coordinated. Really kind of scary. People end up in the hospital just because of being overdosed from pharmaceutical drugs that they've been prescribed by their doctors. So there are some positive changes going on in terms of drug utilization, and part of that is related to the fact that physicians in general are much more sensitive around antibiotics prescriptions as well as other drug prescriptions, and trying to hold back on particularly the people with chronic illness and the elderly not being so free to prescribe medications. So if you look at what is happening now, the annual growth in pharmaceutical spending has decreased from 10.1%, that was about spending in the 1990s, to 2.3% for the period up through 2012. 17% of current pharmaceutical spending is on drugs that will go off patent in the next 5 years. And why is that so important? Do you have a sense as to why that's important?
Because once the drug goes on patent, you start producing generics for a lot price.
Exactly. And you know, I mean, Rogaine, which you guys don't either, so you don't probably even know what Rogaine is, but people use Rogaine, particularly a lot of men use Rogaine to try to stop, you know, hair loss. When that was under patent, it was like $65 for an amount of Rogaine that probably lasted 2 to 3 weeks. You can get it for like $7 now. So what happens when a drug is under a patent is they're charging a very high amount because they're trying to pay for the very high R&D costs that have been involved in the production and identification of that drug. And the government has huge amounts of regulations on pharmaceutical companies, so those are real costs. I don't mean to by any means minimize them, but it's really, really important as drugs are being developed that we can limit that amount of time that they're under a patent, because it really can help us drive the overall cost down. Second major factor is that the use of diagnostic imaging, which was growing at above 6% every year, has been flattened since 2005. And one of the major reasons for that is really a patient safety issue. And many people would get exposed to radiation through various different tests throughout a year. And nobody was keeping track on behalf of that patient. The patients themselves, because they wouldn't have the information, nor their physicians, because they didn't even necessarily know all of the different imaging studies the individuals having. No one was really keeping track of radiation exposure. And it's really been in the last couple of years that there's been a tremendous amount of education among caregivers about the importance of limiting radiation exposure for individuals. Because, I mean, you all know that being exposed to radiation can put you at risk of developing cancer. And we certainly don't want to be trying to treat somebody with something that is going to make them more ill over time. So that's a big factor. Numbers of surgeries are down. Look at bypass surgeries alone. They're down by 20%. That's by no means unique to cardiac surgery. One of the reasons why that cardiac surgeries are down is because there are now medications like statins, which I'm sure you've all heard of, that help with lowering cholesterol, which are basically starting to eliminate heart disease among many populations. So in some situations like that, the appropriate use of medications can have a dramatically positive impact in terms of getting our arms around healthcare costs. And then primary care, which is your family physicians, your internists, your pediatricians, for women often OBGYNs, who are really the coordinators of care, are starting to play a much more important role in the overall provision of healthcare. And that's starting to help with coordination, avoidance of duplication of tests, et cetera, which is being very helpful. Also, when you look at some of the other things that are happening that are driving costs down, we're going to talk a little more about this later, so I'm not going to dwell on it now. But a lot of Medicare patients are getting enrolled in innovative new healthcare models. And as they move into accountable care organizations, again, which we'll talk about a little bit later in bundled payments, that shifts a lot of the risk of the cost onto providers. And the more that the risk of healthcare costs are shifted to providers, the lower the costs drop. And there's a very interesting shift in incentives that I'll talk about in a few minutes that I think is important for you to understand. And the same thing is really happening on the hospital side. Many hospitals are participating in some of the new program and business models that were offered through Obamacare or the Affordable Care Act. And those are starting to actually show a real positive trend in terms of decreasing healthcare expenses. I'm not going to go on and repeat myself with these things, because we're going to talk about them a little bit later. So now I'm going to kind of shift from kind of the context. Hopefully now you have a little bit of sense of what healthcare spending represents. You have a little bit of sense of what the current picture is, which is more positive than what we've seen in year past. And now I want to kind of talk about, what are the things that are happening that are really driving change in the healthcare sector today. And one is that there is fundamentally, I think, a recognition by large healthcare providers like ourselves that we really need to change the way healthcare is delivered. And many of you probably can relate to this through experiences in your family, through grandparents, parents, other friends or relatives, that the American consumer in general has tended to shop and go from and self-refer themselves to various specialists. So you have a sports injury, you tend to go to an orthopod or an orthopedic surgeon rather than going first to your primary care physician, if you have a primary care physician, and I recognize that many young people do not. And that's actually really important, because the more that we can kind of develop relationships between individual consumers and primary care physicians, the more successful we can be in coordinating care better. And that can have a very positive impact in terms of health status, but also a positive impact in terms of controlling costs. And also, we're moving from an inpatient-centric model, which is where people ended up in inpatient hospital environments quite often, to an ambulatory model. And in fact, I would argue almost to a retail model, which healthcare has been very late to adopt. We also are finding a whole new entry of new competitors that are very richly financed by capital investors, and that is having an impact on healthcare delivery and healthcare providers and how they provide care as well. And as I mentioned before, there's a whole new retail orientation developing with healthcare, and I think that's helping to redefine the way healthcare is delivered. And part of that is because a lot of people want to be able to access their healthcare provider on their iPhone. They want to avoid an appointment with a doctor if they don't really need one. They want to be able to, through their computer, do a telephone consultation or a consultation over their computer. So there are a lot of things like that from a technology application perspective that are helping really develop that retail orientation. And also American consumers continue to really want immediate access. Is it frustrating to you if you call for an appointment with a physician and you have to wait 2 weeks for an appointment? In our community, if you need to see a dermatologist, you're lucky if you can get it in 6 months. Well, people aren't going to tolerate that, right? You need to see a medical oncologist with a cancer diagnosis. It's usually 24 hours. But most people will not tolerate 6-month waits, and so that's driving a whole new business model around healthcare as well. There's also a lot going on in the insurance market, which we'll talk about in a few minutes, which is driving change. And a lot more burden of cost of healthcare is being directed back down to the individual. And when it's your money that you're spending, you make different decisions. And then also, there is change being created around the operating model of healthcare, which I'll talk a little bit as well. Traditionally, if you had to define kind of what does the healthcare system look like today, you would tend to think about patients, they would go to doctors, doctors would send patients to hospitals, and it was a really pretty simple model, right? And the reality was that for every time that a doctor saw you, or every time that you showed up for an outpatient test, or every time you had a hospital admission, there was a charge for that. So it was very episodic, and the incentive then was to do more. So if you go see your orthopedic surgeon and he has an MRI unit in his office, he's probably going to recommend an MRI if he's getting paid for that. If he has his own therapist, he may recommend therapy. So the incentives have been all mixed up because they really drive what we consider to be at this point overutilization. This is really kind of the new model of healthcare that is evolving, and it's really built around comprehensive healthcare systems, which are not just hospital-centric, but they really are care-centric. So you've got employed physicians, you've got hospitals, you've got home care agencies, you've got durable medical equipment. To some degree, you may have retail pharmacies, all coming together to work together to coordinate and aggregate services that a certain patient population may require. And then they work on trying to make sure that you're helping people stay healthy as well as caring for them when they're ill. And just to kind of exemplify what I was just sharing, I just pulled some use rates looking at Chicago and the Cook County, which surrounds Chicago and the state of Illinois. And if you look at just what's been happening in terms of inpatient admissions, you see that there's been a dramatic decline, almost 10% in inpatient admissions. If you try to look at that then across a national base, you see that the same thing is happening. That overall, there's fewer and fewer patients being admitted into inpatient environments because care is being able to be provided on the outpatient, which is better, right? Nobody really wants to spend time in a hospital if they don't have to. Then the next thing I mentioned was about new emerging competitors. And let me ask you, CVS and Walgreens are getting into healthcare in a big way. Why do you think they're doing that? What would be the business drivers that are leading a Walgreens or a CVS to getting into some of the more fundamental healthcare services that are traditionally provided by physicians and hospitals? Do you have any thoughts on that?
Maybe because of the aging patient population. I'm not sure.
Well, that's certainly a contributor. Yeah, other thoughts?
I mean, there's obviously demand for healthcare, like tests that with the aging population, especially, and if you have a 6-month wait with your dermatologist, or these hospitals or these primary care physicians aren't meeting that demand appropriately, customers are going to look somewhere else for a competitor, and they realize that.
Yeah, absolutely. And so the minute clinics that have developed around the country, Walgreens is through Theranos, but they're all the same. We run a couple of them. It's a nurse practitioner in a box, right? You just put them in a retail environment, and you can walk in. If you have a sore throat, you can just go in and see your nurse practitioner. No appointment. You don't have to worry about an appointment. And you guys should download something called iTriage onto your cell phones. iTriage gives you the ability to get a physician consultation without ever having to, just a limited number of diagnoses. That they'll even prescribe, if you have a urinary infection, they'll prescribe if your symptoms are typical. By your iPhone, you'll get a prescription that will be either sent by email or by fax to your local pharmacy of your choice. So these new retail types of models that are emerging are exactly about that access. But the other thing from a business imperative, what do Walgreens and CVS want to sell? They want to sell meds, right? They want to sell drugs. That's where they make their money. And they make their money on all the other stuff in the store, which I don't know about you, but as soon as I get in line, I'm always looking at everything else, and I end up buying stuff I don't need. And I think that's kind of the model. So if they get you into the store for the flu shot, then most likely you're going to find something else that you need before you leave the store. So that cross-selling capability is a powerful argument for the retailers to get into it. The last reason is because they all hire and employ a lot of people across the country. These are big employers. Look at Walmart, right? One of the biggest employers in the country. They employ a lot of people. They spend a lot of money on health insurance. So they're also trying to find ways to lower their own healthcare expenses on behalf of their employees. So if they can start integrating some of that stuff into their stores where their employees are working, they're of the belief that they can minimize how much time will be lost and missed from work because of illness, and also lower the cost of accessing the healthcare that people need. So when we think about kind of this retail orientation that is starting to now really deeply permeate healthcare, we think about it from kind of new points of competition. One is around brand. When you tend to think about hospitals and doctors, I'm sure all of you tend to think about you go there when you're sick. You don't think about them as being a partner in helping you stay well. So that's a real problem for healthcare organizations like mine, who are really oriented toward trying to help elevate the overall health status of a community and to help keep individuals well. So there's all kinds of brand implications. There are access implications. As we just said, no one really wants to wait 6 months to see a dermatologist. There's convenience. Making an appointment is not the most, even if you can go online to make the appointment, it's not the most convenient thing to do, right? It's even more convenient as you're driving past somewhere, if you want to stop and have somebody check out your ear because your ear aches. That's even more convenient. Customer satisfaction. You know, I don't know how much any of you have ever, through your employment experiences up to this point, had to work in a service industry where a lot of your success is driven by customer satisfaction. But you know, almost every patient comes with a different set of expectations, and there are some common expectations across different cohorts of individuals. But providing a really extraordinary patient experience is almost a requirement to be successful in any business today. So that's an important point of competition that the new retail-oriented businesses are really excelling in. IT connectivity. You know, you want to know that all of the information about you is shared with all the providers that you're going to. You want to be able to pull up your results, schedule your appointment on your iPhone. So that IT connectivity is also a big, big driver. Consistent quality. I think people want to believe that no matter where they go for healthcare, the quality is the same. That's not always the case, but I understand from a consumer perspective that that's like the baseline. You just assume when you go somewhere that you're going to get good quality. And then price. And we're going to talk more about price because consumers are coming into their own around demanding lower costs for healthcare. So what's going on in the employee insurance market? Have you guys been following some of the debacle about the exchanges? And you know, everybody's been looking for folks your age to sign up for the exchanges, and the younger population has been very slow in signing up for the public exchanges. And a lot of, it's disproportionate now in terms of a lot of sicker people, older people signing up. Well, that can crash the entire model economically. So you have to have more sick people, fewer sick people, more well people in an exchange to make it viable economically. So it's going to be interesting to see how that plays out. But there are absolutely transformative changes occurring in the health insurance market. And it is very much paralleling what has happened with retirement benefits. And when you guys move into your first full-time jobs, and you're going to see that what you thought you might have been given in terms of health insurance or retirement benefits looks very different today than it did 3 years ago. And it looks very, very different than it was 10 years ago. The contract is changing between employers and employees. And this is not necessarily bad. I'm not imposing a value on this. I'm just making a statement that that transition is happening. More and more people are moving to high deductible plans. We are seeing a disproportionate number of people that are coming in with $10,000 deductible plans. Do you know what that means? Do you know what it means with a deductible plan? You have to pay $10,000 in healthcare expenses in a year before your insurance pays anything, right? So unfortunately, what's happening is that people are ending up in these high deductible plans, but they're not saving the money to pay for the $5,000 or $10,000 that the deductible plan requires. So we're finding a lot of people are running into very difficult financial straits when they have to pay for healthcare bills because they're ill-prepared. And partially they're ill-prepared because the healthcare industry does a horrific job in helping people understand what something is going to cost. If you call and ask us what's it going to cost for you to have a baby at Women's and Babies Hospital, well, we start out with this whole thing. Well, it's generally this, but if this complication or that complication or this complication, craziness, right? I mean, we've got to get a whole lot better at that. And also what's happening is that employers, and I'll again come back to this a little bit, employers are really moving more to a defined contribution model, not a defined benefit model. And do you guys have any experience with that? Have you studied at all retirement plans? Do you know what a defined contribution versus a defined benefit plan is? In simple terms, a defined contribution plan is an employer says to you, I'm going to give you 3% of your total compensation for you into a retirement plan if you put 3%. So I'll match 3%, so you'll have a total of 6%. And then you have the option to decide how you're going to invest that 6% that's invested on your behalf for your retirement. Under a defined benefit plan, they take basically your 5 highest years of earnings, look at how many years you've worked, and then guarantee a benefit. So when you retire, we'll guarantee you get $1,500 a month or $3,000 a month or whatever the amount is. So it's the benefit you're guaranteed, not a percentage that's put into your account. Well, I think you can probably appreciate that the defined benefit programs are really much more expensive and unpredictable because of what happens with Wall Street and earnings as well as interest rates versus a defined contribution where an employer just knows, I'm giving you 3%, I'm giving you 6%, you invest it, and then you as the individual take the risk. Same thing is happening with health insurance. So across industries, corporate America is moving away from employer-sponsored health plans that were that kind of defined benefit where they said, we're going to take care of you, we're going to give you a health insurance plan that gives you all of these benefits. You really don't have to do anything other than pay $10 when you go to the doctor's office or $100 if you're hospitalized as your contribution to that. And they're moving to these defined contribution plans where they'll say, I'm going to contribute X amount of money to your health insurance. Now you pick what health insurance plan you want to participate in. So if I give you $5,000 and you pick a plan with a $10,000 deductible, you may be able to get that insurance for less than $5,000, but you're at risk for that $10,000 then that you first spent. So this is a very dramatic shift. And what I'm trying to share and show you on this graph is that the straight line, or I should say the dotted line, the dotted line is referring to the health plans that are the defined benefit, what we traditionally had. And the black line that's ticking up are the defined contribution plans, which is more the high deductible plans. Individuals make the decision as to what plans they want to use the contribution from their employer to purchase. And then just to kind of, again, round out the comment I made about high deductible plans is to show you how the high deductible plans have continued to increase. And we expect that that will continue even beyond what we see it today, which represents about 20%. So private exchanges. You've heard about the public exchanges where people can, it's like kayak, where you can go and shop for hotels or airlines. The idea is you go online, you can study, they have gold plans, silver plans, bronze plans, and obviously the gold and silver cost more than the bronze plan. And you can just take whatever dollars you have to spend and you go online and you can buy that plan. There are some kind of modifications on that theme around exchanges. There are what are known as private exchanges, which are where employers help define what they want that health benefit to be, but they still give the individual the option to buy at what level of deductible, et cetera, they want in the plan. The point is, though, that this is continuing to happen, so more and more and more of the responsibility for health insurance is shifting to the individual. And that has really significant impact. The other really major change that's going on in insurance is before, if you had health insurance and you broke your arm, you could probably pick from a very large panel of orthopedic surgeons that you want to go see. Well, what's happening now in an effort to try to control healthcare costs is that insurers and employers are moving to what we could consider to be narrow panels. So if you go to these doctors that are in this narrow panel, then you don't have to pay anything. If you go outside of that narrow panel, you may have to pay 40%, 50% of the cost, because that narrow panel is agreeing to work with that insurer to keep the healthcare costs down for each individual beneficiary that they're working with. So you're going to see more and more narrow panels that are developing. So, oh yeah, please.
So, on the last slide,
Yeah.
so you're saying, like, if I had a heart attack, if my hospital didn't have the right whatever for it, wherever they send me to go,
Yes.
that would be the channel?
Yes.
So,
Yes, and usually though, it's good that you asked about a heart attack, because usually if it's truly emergent, they can't by law discriminate. So if you were having a heart attack, you should be taken to the closest hospital, right? But let's say you needed open heart surgery. They can say to you, we've got contracts with 3 hospitals in the country. And some of them may mean you have to travel. You know, you might have to travel to Chicago or, you know, Lancaster, wherever. But that's where you have time to schedule the surgery and it's not emergent, that's where they're really applying the narrow panels. But they can't really discriminate against you. There's a law called COLA, which prevents them from being able to really do that. So you don't have to worry if you have chest pain. You don't want to go there closest places. So this is just kind of recapping what I talked about before around the transformative changes going on with healthcare providers. And it's really from moving away from the model of being inpatient-centric and very big hospital-oriented to really focusing on developing a comprehensive health system that is really focused on helping people stay well, not just treating people when they're ill. And that's why all of these various different components of the health system that are noted here become so important. Because access becomes important. You want to be able to have, you know, people be able to get close to where they work and live. They want to be able to see their primary care doctor, be able to get a lab test, whatever that the need may be. It's a real change in orientation and focus that we're going through. And then I know, you know, anybody that's really interested over lunch, we can talk about this in greater detail. But there's a tremendous amount that is being done within hospitals and health systems now to help them prepare for all these changes. And I can go through these in great detail with anybody interested. I would guess that many of you are not interested in this aspect. But there are a couple of big buckets I'll just mention that are activities that are going on now within health systems that are really helping them prepare for these transformative changes that are going on in the healthcare sector. And the one is really developing all kinds of new tools and competencies that we didn't have before that become really important. And one of that is developing a central data repository. You know, in the past, other than Medicare and Medicaid, there's no way to be able to know even if a patient of yours got their prescription filled. Because there was no central data to be able to look at all of what's happening with an individual patient or a lot of patients. Well, that's changing, and we're now using claims data, the data that processes the payments for healthcare services. We're now being able to aggregate that claims data to be able to understand what's happening with individuals like yourselves, as well as what's happening with an overall population. So that's really helpful. And of course, there's a lot of more detailed clinical and financial analytics that come along with that to be able to help us make better decisions around how we're going to care for people, particularly for people that are at risk of chronic illness or who have a chronic illness. The second is engaging patients in new and different ways, and I hope exciting ways. And part of that has to do with applying technology and making your iPhone, which is your most accessible computer, one of the primary ways in which that you interface with the healthcare system. Health education is a big part of that, as well as web-enabled tools. The next is around creating these new business models. You've read about accountable care organizations and bundled payments. That's all coming out of the Center for Medicaid and Medicare Innovation, which was started by President Obama as part of the Patient Portability and Affordability Care Act. And those are just, again, creative new models to help, creative new models to be able to help healthcare systems be more at risk for the overall cost of healthcare. Launching new programs that will support emerging business models. There are tremendous news. There are things called now that we are experimenting called hospital at home, where all of the services that are traditionally provided in a hospital are being brought to a patient's home. which has been tremendously successful, particularly with elderly patients who tend to get very confused when they're in a hospital environment. Patients that are in medical homes is a team-based approach to care that primary care offices, Norlanco Family Medicine, which was our big Elizabethtown practice, is a patient-centered medical home. So there are a lot of very unique and very creative programs that are being developed to respond to the unique needs of smaller groups of patient populations. And then physician engagement and alignment. When I started working with Lancaster General Health 15 years ago, we had about 80 doctors that were employed by the health system. We have 520 employed physicians today. So we're becoming a much more tightly integrated organization where physicians, hospitals, home care, home infusion, information technology, all are working together in that big health system kind of diagram that I showed, which we think ultimately will result in better care for patients and for lower costs. So that's basically what I wanted to share with you today. I'm happy to explore anything in the slides or help answer any questions about healthcare that I didn't touch on in my formal comments. Yes?
So you're talking about some of the things that hospitals are doing to try to bring the cost down, which is an important thing.
Yes.
But I'm relatively familiar with the healthcare system. It seems to me like a lot of the costs that are accrued by healthcare systems are kind of out of their control. Like you have malpractice expenses, you have, like you said, the cost of pharmaceuticals, and but even if you have an emergency, like somebody has a heart attack and you find out they don't have insurance and they never pay. Well, like how do you get those expenses down? Like, can you ever bring the expenses down to somewhere that they need to be while those other things are still happening?
That's an excellent question. I kind of estimate that about 27, 28% of our expenses are non-controllable. We have no influence over. But there are a lot of things that we do have influence over. And one of them really has to do with utilization. If you're getting paid every time you admit somebody in your hospital, you're going to tend to make a decision to admit more people into your hospital, right? It's borderline, I'll admit them, it doesn't hurt the patient, it's better for us. Well, if you're getting paid on a per capita basis, if our health system is responsible for your health care and we get $5,000 a year to manage no matter what happens to you, our incentives are totally different. So we try to provide as much as we can in low-cost settings, right? So that's the transformation, the flip that is occurring. And so there's a lot we can do to change the way we provide care that can help avoid costs and avoid duplication. We're always astounded by the number of people that we end up working with that have had duplicate tests repeated in a year because their doctors didn't talk. Well, we have what's called My LG Health, and it's a patient portal which allows you to go on and look at your medical record. And we have about 550 doctors that participate in that now, plus about 180 independent physicians that participate. So now when the doctors are all using the same medical record. That never existed before. So now when the orthopod wants to order the MRI, he looks and sees, well, you just had an MRI in the emergency room, he can pull up the MRI. He doesn't need to repeat it. Those are the ways that we're going to really impact costs. The stuff that you touched on, other than trying to use our muscle to negotiate better rates, there's a lot of that completely and totally out of our control. Some of the new oncology drugs are costing us 3 times what we get reimbursed. You know, and there's real question around if they're going to really change quality or extend the amount of time somebody is able to have a quality of life. But, you know, I mean, once there's a new drug, everybody wants it, right? So you're absolutely right. We struggle with those things, but we still feel there's 70% of what we do every day that we can influence in a meaningful way to lower costs and to hopefully help people be healthier.
So I guess the next question would be if you have this switch from, you're saying like moving to a per capita based payment. Per capita, okay. Is there a fear that this could switch in the other direction now, rather than overutilization, we're having underutilization, that these hospitals are now too concerned about money? Well, maybe they don't need that test that they should probably have, but we wouldn't save money for ourselves.
Yeah, absolutely. You have to have all the right kind of quality indicators in place so that you're monitoring that. And part of what you're accountable to the government for or accountable to an insurance company and to the consumer, is that you have to be able to show how you're performing against your prevention and wellness indicators. So there are protections built into that, but yeah, I think that's a really reasonable concern. I mean, we certainly haven't seen that play out yet, but we're still early in this, and I think if people are acting ethically, that doesn't happen. But yeah, it reverses the incentive, so you could undertreat. I think the real safeguard, though, are the quality indicators. You have to report exactly how many people got mammograms and prostate exams, and how many people had annual appointments and got their flu shots. And we have 86 clinical indicators that we have to report to the federal government on for the people that we have in our ACO, our accountable care organization. So I think there are safeguards, but that's a very reasonable concern. Yeah?
What is the average annual cost of healthcare associated services? And what are you doing to
Yeah, hospital-acquired infections is a really big deal. And unfortunately, a lot of like when people talk about MRSA, which you may have heard about or read about, there is as much concern about community-developed MRSA than there is about hospital-acquired. But we have a very, very focused program and effort to try to eliminate hospital-acquired infections. And every month, every single infection that is developed while somebody's been hospitalized goes through what we call an M&M conference, is reviewed. And we try to understand, how did that occur? Did somebody come in with MRSA? Did somebody come in with an infection that we didn't catch? Did something happen in the OR? Because it's often surgical patients that develop the infections at the surgical site. So we try to review every single case, and our infection rates have dropped dramatically over the last 5 to 6 years. Hospitals also are penalized by Medicare there's something called the value-based program, where they have things that they talk about them as actually they pay you more if you do well, but the reality is they're taking money away from you. So if you don't do well, you get deducted from what Medicare is paying you. So there are real incentives for hospitals across the country to be focused on things like surgical site infections and overall hospital-acquired infections. And nationally, those rates are really, really coming down. So now our infectious disease doctors are most concerned about what they're seeing patients presenting in the emergency room with. And college campuses are really becoming more known as a place where patients, or students are acquiring MRSA. So we've got it wherever people aggregate and have shared living, we've got to be really concerned to I think health systems have to work more closely with institutions of higher learning to figure out what we've learned in the hospital environment that can be brought to bear in environments like colleges and universities. That's a good question. Have you read a lot about that? Hospital-acquired infections? Oh, do you? Yes, you know a lot about it. Yeah. Yes?
Some of the slides about the retail, just the public not putting up with or questioning, wanting to know prices. Culturally, it seems like we've got a long way to go.
Totally. I'm with you.
And just a personal example, having switched insurances recently and worked with, went to pick up my daughter's prescription. My old insurance, basically covered all. She had her amount changed, milligrams. Here's the bottom line: packaging-wise, they didn't have the pharmaceutical, and it was one of those drugs that you pay a lot for, but it's still under patent. They didn't have it in the right amount packaged, so I had to go with more of the lower amount. It ended up costing me $50 more for packaging.
Did they not offer to get it for you and have it for you like the next day?
No, it's all this, it's on back order, we don't know.
Oh, wow.
So in my world, as a business person, it's like, in a normal world,
Yeah.
the company should be paying the price for the inconvenience they're causing me. And they should be offering, but when I looked at the pharmacist and said, you're kidding me, I'm paying $50 more for a little bit more cardboard and bubble wrap. Come on now, and you can't argue. It's like, take it or leave it.
Yeah.
This is what they have. You've got to take 3 packages of the 20 milligram instead of and that just blows me away that there's nowhere to go. And she looked at me like I had 3 heads for even assuming something should be done about that. You know what I'm saying?
I think your point is very well taken. There is a tremendous amount of cultural change that needs needs to go on in every aspect of healthcare. And I think unfortunately, because for so long, consumers had very little to do with the healthcare transaction, they didn't pay for anything, right? And so in many ways, we became entitled. I think now that that paradigm is shifting and, the whole insurance changes that I talked about, that's why that's so important. Because it's now, with consumers being much more actively aware of what they're paying for, if it's for the drug or for that lab test or whatever, they want to know price transparency. They want to know what they can do that would cost less, right? They want access, convenience, service. So it's putting a lot more pressure on an industry which has been really not in a retail mindset at all. So
And in
yeah,
this
it's a journey.
Yeah, in this case, the manufacturer benefits from not having
Yeah,
a product in
right.
stock. It's like, where else does that
Right.
happen? That's not a good
Right.
business model.
And one of my personal biggest, I had two huge disappointments with the Affordable Care Act. One is that there's absolutely zero incentives for consumers to adapt healthy lifestyles, right? So there's no consumer incentives, which I think is a huge mistake. And that may not be an issue for you guys, but the general population, it's a huge issue. Getting people to eat right, to exercise, et cetera, is, obesity is a national epidemic. The second really disappointing part to me is because the pharmaceutical lobby was so powerful, there was no changes on the pharmaceutical industry at all. And I find that unfortunate, because I think they've got to be a partner with the rest of us at the table. It's the largest sector of healthcare spending, and they're critical. And they were not impacted by the Affordable Care Act at
Well,
all.
even if you went along with hospitals, because we're talking about
Right.
being paid a certain amount to care for the patient,
Right.
the pharmaceuticals should be in on the same thing.
I agree.
You get a certain amount, and that would also level off the patent thing. Because it's kind of sad if you happen to need a drug, whether it's patent years, and you got to pay a fortune for it, and a year later, it's on the street.
That's right, absolutely, yeah, I agree with you there. Yeah.
So you mean, so the Affordable Care Act doesn't do any like incentives, like I know Highmark, they, go to the gym, they will like, give you money for, mostly, like. is that
Well,
what-
yeah, and Highmark does some things. I mean, I think they could, even Highmark could do a better job. At least they recognize it. I appreciate that. But in some of the original state demonstrations, they actually financially incentivize people to increase the activity in their lives and to invest in more healthy eating. And so the primary care physicians were actually waiving primary care fees altogether for patients that were meeting the requirements from a healthy living perspective. Participating in gyms, so it's a whole bunch of stuff people could do. They eliminated, even though it showed great success in the demonstrations, they eliminated it. And they eliminated it primarily because the Medicare lobby did not want those incentives imposed on elderly people. But I think that's unfortunate. I think we all have to take responsibility for our health.
No. What you're saying about moving these high deductible plans and people paying more out of pocket, doesn't that kind of create an incentive there to, if I'm living a healthier lifestyle, I'll get sick less, I'll have to pay less of this deductible because I'll have to go to the doctor less. Do you think that's an incentive, or are people not going to realize that and not think that far ahead?
I think it is an incentive, but the same risk that you raise around your healthcare provider is a risk of listening to patients, that they're not doing the basic prevention. And I do worry about that long term, that, I've literally had people that I've talked to say to me, well, if it's food on the table or if it's me going for my mammogram, guess what? I'm not doing my mammogram. So, you have to worry about it on that end as well. But I think for people that are not struggling with basic subsistence, I think that it is an incentive that if you can prevent healthcare expenditures and keep more of that contribution that you got from your employer for health insurance, and you've done well on a high deductible plan, which young people do very well on high deductible plans in general. I think then it can really work for you. But way too many people, even with, it doesn't, you could be somebody that's diabetic, hypertensive, and you could be on a high deductible plan. How does that work? It really puts a lot of the risk back on the individual. And that's what we're seeing, so many more people that just can't afford to pay their deductible. They just can't afford to pay it. So it's increasing our bad debt,
Right.
our free care, So I know you guys have to go. I hope this was helpful having you